whether patient is conscious or unconscious. Let's say patient is conscious. Hey man, what's your name? Whatever your local language or any language that you use, ask the name of the patient. That's the first thing if the patient is conscious, because that will give you an insight what is going on. If the patient is unconscious and if the patient is not responding, if the patient is not responding, then you have to look for the added sounds, like any stridor is there or any cyanosis is there. And if the patient does not respond to any questions, then immediately you have to think of the resuscitation part. Now, I'm an orthopedic surgeon. People don't expect me to do this, but I want you to do this. There is a sequence of event of resuscitation. The first step is always the chin lift, to prevent the airway falling back. Then you have to apply the jaw thrust. Then you have to swipe your finger so that any, it can be a broken tooth, it can be a loose body, it can be a mucus, it can be a vomitus, it can be a gastric aspirate, anything can be there. So the chin lift, jaw thrust, you have to swipe off your finger, you have to do the suction. If at all the patient is not resuscitating back, the vitals are not stable, then you have to put a oropharyngeal or a orotracheal tube. If not possible even after that, then cricothyroidotomy or tracheostomy has to be there. But the first 4 steps, I want all of you to practice on your patients whenever you land up into a scene of a polytrauma: chin lift, jaw thrust, finger swipe, suction. Now, after airway, cervical spine resuscitation, the next thing that comes is breathing. Now, when I say breathing, I will be very clear with you. There are only 5 important points. Number 1, expose. Number 2, look at it, inspection. Number 3, feel it, palpation. Number 4, look for the movements. Number 5, auscultate. You have to understand. Breathing is very simple. I will mention something that my senior used to mention. He used to say, Tushar, if airway is the anatomy, breathing is the physiology. आप मेरी बात समझिएगा. My senior, when I was getting training for ATLS, my instructor used to tell me, if airway is anatomy, breathing is physiology. He used to say airway rasta hai, zariya, anatomy, tract hai. And that tract has to be kept patent. It has to be kept open. You can do that even bloody sitting on a road with a road traffic victim with you. But when you talk about breathing, if airway is anatomy, breathing is physiology. Airway rasta hai, breathing uska zariya. That the patient has to have a proper modality of inspiration and expiration. So you have to expose the patient, you have to inspect the breathing pattern, palpate it, move it, see the movement, and auscultate it. Now, there are 5 things. There are 5 life-threatening thoracic conditions: tension pneumothorax, massive pneumothorax, open pneumothorax, flail segment, cardiac tamponade. These 5 things are those 5 things in which, okay, fine, I'm not talking about myself, I'm talking about you. Considering that you are, MBBS students or, done with MBBS, these are the 5 important things when you have to give a shout out to a surgeon, because a surgeon will come and will manage these 5 important things, because these are the things which are going to kill the patient. Now, after airway, after breathing, then comes circulation. Now, when I say circulation, circulation does not only mean checking of the vital statistics. It also means the hemorrhage control. It also means the hemorrhage control. So, tachycardia in any cold patient indicates shock. For me, it's very simple. Any cold patient, tachycardia, for me, it's very simple. It is shock. Now, there are 4 types of shock: hypovolemic, cardiogenic, neurogenic, septic, as we all know. I'm not concerned about that. All I'm concerned about is the hypovolemic or the hemorrhagic shock. How do I assess the blood loss? The first thing is that the bleeding can be external or internal. Guys, it is very simple. या तो बाहर खून बह सकता है, अंदर बह सकता है. External will be obvious. It will be visible. You have to apply a tight bandage, you have to apply a tight tourniquet, you have to close that bleeding. Simple. If it is internal or covert, there are 4 areas which bleed like anything. These are the 4, I would say the 3 are the cavities: the chest cavity, the abdominal cavity, the pelvic cavity, and the 4th one is limbs. So आपने अगर airway manage कर लिया है, आपने अगर breathing manage कर लिया है, when you come to circulation, the first is to see what is bleeding, external or internal. Now, once you see whether it is external or internal, then you have to resuscitate that part again. How? You have to arrest the bleeding. You're not supposed to give the fluids first. This is again a kind of a wrong practice. I've seen residents not doing that. I have seen residents not doing that and actually landing into a soup. I'll tell you how. Immediately they push a lot of fluids into the patient. Before finding out the source of bleeding and controlling the bleeding, they just start to push the fluid. That is not a good thing. So first step is to always arrest the bleeding. Now, once you have arrested the bleeding, external or internal, now something that I want every medical student should know. Every medical student in the country should be aware of the fact that if the polytrauma victim is an adult and you are sorted with C-spine, airway, breathing, and control of the bleeding, if the patient is an adult, beta 2 liters of RL should be given as an initial fluid challenge without an inch of a doubt. कुछ नहीं सोचने का. 2 liter RL push. If there is a children, you have to assess the body weight, which you will be able to assess by asking the parents or anybody around, or just by looking at the children. You can see that 20 mg per kg. I don't want a fluid overload in kids also, so that's why 20 mg per kg. इसमें सोचने का नहीं, बस ये बोल देना बस 2 liter in adult and 20 mg per kg RL in children. Now you have to see that this fluid challenge that you are going to give, you have to see what is the response to this fluid challenge. 3 options are there. A, there will be immediate return of the vitals, which will be sustained. Second, there will be a slight delayed response, but that might deteriorate later. 3, there is no improvement. 3 बातें हो सकती हैं, एकदम से ठीक हो जाएगा और रहेगा. दूसरा थोड़ा ठीक है, delayed है, but it deteriorates. And the next one is that there is no improvement. If there is no improvement and if there is a latter deterioration, I'm telling you, in majority of the road traffic accidents, this is the culprit, pelvic fracture. I'm an orthopedic surgeon. I deal with fractures. ATLS doesn't consider me because I have told you, they say life first, limb later. मेरे को तो रखा भी last में है. A, B, C, D, F. They say F is the last. Fracture is the last. Okay. But you know what? They cannot, they can ignore me, but they cannot live without me. To manage a circulation, you have to take care of the fractures. Because the majority of the people who do not respond to your fluid resuscitation are actually having some pelvic fractures. And there comes the role of an orthopedic surgeon, because if he is not going to apply a pelvic external fixator, no matter how hard you try, no matter what blood you give, no matter how much fluid you push, you just cannot resuscitate the patient according to the circulatory parameters. And that's why the pelvic external fixator, I'm sure you can see the image also, it has to be applied. Once you apply the pelvic external fixator, the moment you give the compression, immediately vitals will restore. Now, again, not wanting to go very fancy with you people, but still just to giving you an idea about, the hemorrhages. When you give a lot of fluid push, there are 3 types of responders here. One is the immediate, second one is the transient, third is a non-responder. Immediate responder is going to have less than 20% of the blood loss, bleeding is going to stop. Transient responder is that in which there is a bleeding inside the cavity, surgery has to be there, surgical intervention has to be done. You call a surgeon, he'll do a laparotomy and move ahead. Non-responder is more than 40% of the blood volume lost, and they require immediate surgery, and probably in the majority of the non-responders are pelvic fractures. Just keep giving IV fluids is not going to help. Without performing the surgical intervention in transient and non-responders, just keep giving IV fluids is going to be detrimental. Now, I would like to share one more thing here. I was a first-year PG resident. I had a patient. It was a case of polytrauma. Listen to me very carefully, interesting story. It was a case of polytrauma, and I was standing besides the bed, behind the bed of the patient, and the CMO and anesthetist and medicine resident, as usual and always, were taking care of that patient. I was not even knowing what is ATLS by that point of time. So they were doing resuscitation, somebody was intubating, somebody was taking care of the hemothorax, and all those fancy things were happening in front of me. And as an orthopedic resident, my concern was only that once you guys will be saving his life, I will get an X-ray done to see which fracture is this. आप समझ रहे हो, the tubular vision, छोटी सोच, the narrow mindset, कि ठीक है तुम जान बचा लो, बाद में जब हो जाए मुझे दे देना, मैं X-ray करा के देख लूँ. My boss, my senior called me. He said, Tushar, I heard there's an emergency. I said, yes, sir. What do you think? I said, sir, polytrauma. He said, so how are the vitals? I said, sir, they are managing the vitals. He said, bloody hell, you are sitting there, you are standing there, you should also know the vitals. I said, okay, sir, I'll just wait, sir. So I looked at the monitor. I looked at the pulse. It was around 100, 102 or something. I informed him. I looked at the blood pressure. I informed him. He said, what is the other circulatory parameter that you want to inform? I said, sir, pulse bata diya, BP bata diya. I don't think there is anything else. And he said, okay, I'll talk to you about this tomorrow. And he said, the third thing is basically the urine output. As a medical student, I don't know why, but in our infrastructure that we have, urine output is one of the most neglected parameter for circulatory assessment. कम से कम मुझे 15 बार डांट पड़ चुकी है in my PG. Minimum 15 times I had a bashing from one of my seniors that in vitals you did not mention the urine output for 24 hours, last 24 hours in the chart of the patient. I said, sorry sir, I forgot to look at the Eurobag. But please try to understand that urine output is very, very important, and you should be able to know what is a normal urine output, and therefore I've mentioned here also. So the circulatory assessment is not only by some pulse and BP, it is by the urine output as well. Estimation of blood loss, I have made things very simple so that a medical student is able to understand any fracture of the rib cage or involving some lung parenchymal damage will have 2 to 4 units of blood loss. Proximal humerus fracture 1 to 4 units. Pelvic fracture, wow, 2 to 6 units. Femur fracture 2 to 4 units. Knee dislocation 2 to 4 units. This image is very, very important. It should be kept in your mind because they are going to tell you about the estimation of the blood loss. So guys, in ATLS, in primary survey, till now we have spoken about airway, we have spoken about breathing, we have spoken about circulation. Now we come to disability limitation. Now, when I say disability limitation limitation of what? The brain, the central nervous system. So a rapid assessment of motor functions and sensory functions is required. And then you have to see the AVPU pupillary assessment by the pre-hospital personnel. I mean, this is something that I want all of you to do, even at the site of the accident on the road. God forbid, if you land up into such a scene, better please try to understand. You should be able to know AVPU, A, alert. B, response to voice. P, response to pain. U, unresponsive pupil, size and reaction. They are, of course, to be mentioned. Many students, even when I was a student, I thought that this D, disability limitation or neurological assessment, should have a Glasgow Coma scale. No, that is a part of the secondary survey. Usually, it is a detailed score, so we keep it for secondary survey. In primary survey, we keep AVPU. Alert है कि नहीं, आवाज सुन रहा है कि नहीं, पेन करने पे उसको स्टिमुलस देने पे पेन होता है कि नहीं, pupil कैसा है. After A, B, C, D, now comes E. What is E? Exposure and environment. My boss used to say one thing, my instructor, I am a person who has not been very fond of books, but been very fond of my seniors, my people, because किताबों से कभी नहीं पढ़ा, मुझे लोगों नहीं पढ़ाया. So that's why I use this slang often. So my instructor used to tell me that, Tushar, expose the patient, undress the patient completely. And then he used to say, look for every single occult site. I hope that you can see that there is an injury on the buttock here in the image onto the right hand side. It has happened with me, boss. It has happened with me during ATLS primary assessment survey. I missed an injury inside the axilla. Another patient, I missed an injury on the natal cleft. I don't want you people to do that. I always try to, tell you my mistakes so that, you don't think me as of something, which is like a superhuman. No, we all have done our mistakes, and it is very good to do mistakes. So exposure is one point of ATLS जिसको लोग समझते नहीं है. Many people they underestimate this part. क्या ठीक है, why to undress the patient? No, completely undress the patient. Look for all sites of injury, and then my instructor used to say, Tushar, make sure to dress the patient again. ठीक है, कपड़े उतार के उसको देख लिया, लेकिन पहना भी देना, otherwise the patient might die of hypothermia. So these are the 5 integral components of ATLS, A, B, C, D, E. And now comes my business where I start my job and from which I benefit, that is fracture. There is no classification of a fracture like minor, moderate, serious, severe. Of course, the family says the polytrauma patient is there, the parents will come, relatives will come, doctors, what has happened? We inform them. T-spine is stable, airway is stable, breathing is fine, circulation is okay, we are pushing fluids, he's responding, he's alert, he's responding to voice and pain. There are a couple of fractures. Doctor major hai ki minor hai. There is no classification for the patients, but there is a classification for doctors. Minor is just to be ignored. I don't want to mention anything in minor. Moderate is just you have an undisplaced long bone or a digit fracture. Serious is multiple fractures. Severe is, I mentioned the whole list here, but I don't want you to go through the entire list. I just want you to know any pelvic fracture or any open long bone fracture is a severe fracture. Now, when we talk about fractures, again, that requires an immense support, that requires an immense control over the patient, because you have to have a multimodal approach. Splints are there, braces are there, plaster casts hote hain, tractions are there, surgical options are there. There are many options. But now comes the very important part, is decision making. Here I would like to tell you that, many people feel that, I mean, there are different people who have different personalities. Like there are certain people who are always high on adrenaline. होते हैं कुछ लोग ऐसे. They always want challenges in their life. They always want to be, in command of the situation that they are in. उनको लगता है कि they like chaos because they know that they are able to solve chaos. They are surgeons. They are orthopedic surgeons. So decision making, a critical decision making is very important. So if the patient is responding well, I mean, guys, you have to understand, we are done with ATLS, right? हमारा ATLS खत्म हो गया. Now, if the patient is responding well, then you have to move ahead with the secondary survey. If the patient is responding like transiently, then a CCU, critical care unit, is required. A second round of survey and resuscitation is required. If the patient is not responding at all, again, critical care unit, but probably some bleeding inside, and shift to OT. There are 6 basic medications which should always be available at any given point of time, and I want all medical students to know about it. Tetanus prophylaxis, I'm sure you guys are aware of it. Steroids, sometimes there is a patient who has come to you with a neurogenic shock. Steroids are important. Inotropic drugs, let cardiology people take care of that. Orthopedic surgeons should not intervene. Antibiotics, universal, basic, gram-positive, gram-negative, anaerobic coverage, calcium gluconate and bicarbonate. So these 6 should always be there on your cart. I hope you remember that in the beginning of ATLS, I told you that there are 2 policies. One is the the slay and play policy. Another one is scoop and run policy. Another thing that I told you, the access of the patient is very important. You have to be very careful with that. I'm sure you can see such kind of wreckages. It is very difficult to even take the patient out. Now let's talk about, in a very brief, I will be taking the secondary survey. Now, when we talk about secondary survey, it comprises of a complete thorough examination. हमारे यहाँ बोलते हैं सर से लेके पैर तक, right from head to toe, tip to toe, examination of the stable patient. So guys, I hope till now we have made the picture very clear. We are thorough with ATLS, polytrauma victim. We have survived the patient. We have resuscitated the patient. We have gone through the entire journey. The patient is not responding. Now further secondary survey. So a complete thorough examination head to toe. होता क्या है? What is secondary survey? People don't understand what is secondary survey. Detailed history. How it happened, when it happened, what was the force, what was the mechanism, what was the mode, what were you conscious or not, did you vomit or not, all those things. Thorough examination again. Check for vitals again, pulse oximeter again, oxygen saturation again, rectal thermometer again. Detailed process, detailed radiographic investigation, CT, USG, MRI, whatever you wish to do, you go ahead. So all the investigations, like this is an MCQ, I'm telling you, ATLS includes all of the following except cervical spine stabilization, airway management, resuscitation, complete CT analysis of the body. No, CT analysis, MRI analysis, USG analysis, they come in the secondary survey. Head, Glasgow Coma Scale. I hope you remember, I told you that in primary survey, normally we take AVPU. In GCS is something which is a part of the secondary survey. Reaction of the pupil, size of the pupil, plantar response. I'm sure everybody is aware of spasticity, UMN, LMN, and Babinski. Signs of rhinorrhea, otorrhea, CSF leak, any skull base injury is also be looked upon in secondary survey. Glasgow Coma Scale. 3 important components: eye, motor, verbal. 3 is minimum, 15 is maximum. You are aware of it. In secondary survey, after head, we have spoken about head. After head, we have neck. Neck, very simple. Look for any emphysema, look for any cervical fracture, look for any penetrating injury. Cervical spine injury, you will be able to see only on an X-ray. And mind you, I repeat again, there are only 3 X-rays which are allowed in primary survey. What are the 3 X-rays? Number 1, cervical spine lateral view. Number 2, pelvic X-ray. Number 3, chest X-ray, AP supine view. So if there is any cervical spine injury, get to know about it on an X-ray. If there is any injury of the thorax, so I'm trying to cover secondary survey according to the system. Head is done, neck is done, now thorax. ऊपर से नीचे आ रहे हैं. In thorax, pulmonary complication, cardiac tamponade, myocardial contusion, aortic tear, diaphragmatic tear, esophageal tear, all these fancy tears and big things have to be taken over by a specialized cardiothoracic team. The only thing that you can do sitting over there in the casualty is that after thoracostomy, after the thoracic tube is placed, if the bleeding is more than 1500 ml, you should inform a CTBS team that come and perform the thoracotomy. So after head, neck, thorax, let's talk about abdomen. Again, something I would like to quote from, the head of the department when I was in my MBBS days. He used to say, any polytrauma victim, any resident should be aware of the fact that orifice and that fingers and tube should be there in every orifice of the body. वैसे बोलते थे, every cavity में या तो उंगली या तो tube डाल के रखो, then only you will be able to save the patient. So this first line is something very close to me because this was one of my initial learnings that he used to give us. Finger and tube in every orifice, Tushar, that you can even think of inside the patient's body, whether it is a nasal cavity or the genital cavity. Nasogastric urinary catheters for diagnosis, rectal examination. If there is wound, that has to be covered. I'm sure in due course of time in your clinical career, you will see people of polytrauma coming to you with eviscerated bowel. Loop of intestine bahar pada hoga. So it is at that point of time you have to control yourself first, calm down yourself, and then you have to take some warm, wet, saline mops, and you have to put that mop on that eviscerated bowel, and manually, digitally, you have to make sure that you put those bowels back. So get ready for all this. Now, this is something particularly surgery component, not orthopedic surgeon, but still I would like to give you an idea. Distended abdomen, rigid abdomen, a 4-quadrant percussion is required. A DPL, diagnostic peritoneal lavage, is required. Then FAST, the ultrasound, is required. And then you can go with laparotomy or laparoscopy. And if the patient is deteriorating, open the abdomen as soon as possible. There are no brownie points for saving the surgery. Similarly, when we talk about urology, if there is any, I will just simplify the slide for you. If there is any blood at the tip of the external urethral meatus, better please think of a pelvic fracture with a urethral injury. There is no possibility that a patient with a blood of the tip of external urethral meatus is going to have just a urethral injury. It has to have a bladder rupture, extraperitoneal, intraperitoneal. Anything can happen in the urogenital tract. So you have to have a trial of a catheterization with very gentle manipulation. You have to put a lot of lubricant. You should ideally do it in a minor OT. That is very important. If you're not able to do that, then go ahead with suprapubic cystostomy, because that is going to be very good for the patient. As an orthopedic surgeon, I've dealt with a lot of life-threatening injuries. Sometimes they make you vulnerable also, and you're not able to sleep in the night, that you were not able to save the patient. Probably the patient didn't come to you in time, or whatever the cause may be. This is one pelvic fracture, an unstable open book injury. Fixator was applied, and pelvis was reduced, and urethral injuries were taken care of. The patient survived. Now, this is something that not many people can control. Like, even I feel at times I have failed in managing a spinal injury. Thorough examination, sensory motor is important. There is an unstable fracture, you have to prevent further damage. Log roll position is very important, and 5 people are required. I'm sure you guys have heard of log roll position, that 5 people, they hold the patient, normally 2 on the sides and one on the head and 2 on the foot, and then they shift the patient as such, as a whole, like a log roll, and use a long spine board for transportation. The head board should be long enough to accommodate the patient. There are different mechanisms of spinal trauma that you have to ask in the detailed history in the secondary survey, that whether you fell on your neck, or whether there was a whiplash, or whether there was a hyperextension. Because students, you have to understand, by knowing the mechanism of the injury, you will be able to assess better that what you're going to be seeing on an X-ray, because you know that which injury causes which fracture. Extremity comes only after head, neck, thorax, abdomen, and spine. Did you see? I tried to give you in terms of the hierarchy of importance. So head, neck, thorax, abdomen, spine, now extremities. So assessment should be there. Look for the distal neurovascular status, look for the skin and soft tissue, and if there is any impending compartment syndrome or not. Actually, there comes the role of an orthopedic surgeon, but since I was always inclined towards ATLS, I gave you the overview of the entire primary survey, resuscitation, and secondary survey. Open fracture, dislocation around the elbow, massive injury, we applied external fixator, skin healed well, everything went well. Again, an open tibial fracture, external fixator was applied, things went well. Just sharing, external fixator, it is a very important tool for emergency management of a fracture. Another railroad fixator. By the way, this came as a MCQ in the NEET PG also. This almost similar kind of an image came in the exam. This is a railroad fixator. This is a plain external fixator. I'm sorry, I can't stop MCQs from coming out of my head. Hota nahi mujhse control. This is a railroad fixator. The same image was there. When you see a black carbon rod, which is all cylindrical all around. This is a railroad fixator. Whether the extremity is crushed or not, whether it is salvageable or not, that can be assessed by a score called as Mangled Extremity Severity Score, MES. I would like to say that whether the limb is messed up or not, you can get to know about it from calculating MES. There are 4 components. One is the skeletal soft tissue injury. How much is the patient is in shock? What is the level of ischemia? What is the age group? So SSIA 4 components are there. We will not get into the details of the score, but if the score is more than 7, there is no chance of saving a limb like this one. So it's a clear-cut pilon fracture with an open dislocation of the ankle. It was badly crushed, and saving it was beyond possibility. You can see another crush injury of the wrist here involving the distal forearm as well. Now, there is one thing that I would like to mention here, that initially I told you that trauma center requires this much people, but you have to understand it is a multi-speciality approach. It is a multimodal approach. Standalone surgeon or a standalone orthopedic surgeon cannot manage. It is an interdisciplinary management. Sabko ek saath milke kaam karna. It is a multimodal approach. And a surgeon or an orthopedic surgeon is usually the captain, as I've already told you. Spinal fractures are there, orthopedic surgeon, neurosurgeon, they come into role. Plastic surgeons are required for the flaps. There is a current concept that I want to tell you about, permissive hypotension. Now, permissive hypotension is very simple, that you have to maintain a systolic BP at around 85 to 95 millimeters of mercury. The last line that I've written here is very important. Turn off the tap. What is the tap here? Tap is about the bleeding part. This is something which again is an MCQ. So you have to control the bleeding first, and please don't infuse too much of fluid and blood products. लोगों को लगता है fluid और blood देने से सब ठीक हो जाएगा. नहीं. Many casualty residents I've seen, many casualty medical officers are doing that. They're just instructing somebody over the phone, push another 1 liter, push another 1 liter. No, don't do that. If you're pushing fluid, still the vitals are not resuscitated. That means there is a tap which is leaking. So please turn off the tap. That is more important. The last slide of this thing called as emergency orthopedic management, high velocity trauma. I mean, this is something that I believe in. I've written it with all my heart into it. High velocity trauma is aptly called the neglected stepchild of modern civilization. And it is now the #1 cause of death in the young population, the most fruitful population of the country. Despite the economic productivity, we have, but this problem that is there in terms of morbidity and mortality, it receives less than 2% of the total health budget allocation. So it is the time that people have to work hard. We are doing a lot of efforts on people, who are suffering from COVID and all those things. We've never invested in healthcare as much as we should have and we could have. But it is a good time to learn now, not only in epidemiology or microbiology or mental health. We have to invest in, bottom line is we have to invest in health. And investment in health is not only I'm blaming or I'm allegedly saying that government has to do. We all have to do. We all are. हम क्या कर रहे हैं? हम सब देख रहे हैं. दुनिया में हम सब क्या करते हैं? हम देखते हैं. We are judgmental people. We just judge people. We judge their actions. We judge their consequences. He should have done that. He shouldn't have done that. We make fun of people who are into their wrecks. Natural calamities are happening all around the world. This year has never been good. But as a student, if you are listening and watching me right now, my simple question is that you are into the field of medical profession. What do you want? My simple question, what do you want? You want a giant leap of faith. तुम्हें क्या चाहिए? तुम सब जिंदगी में आगे बढ़ना चाहते हो. मैं भी बढ़ना चाहता था, बढ़ना चाहता हूँ अभी भी. The zeal is still there. We all want a giant leap of faith. On one side, we are MBBS. We can be a medical officer. We can be a general practitioner. But what is there on the other side? Just before me, there was one of the leading surgeons that you had, Dr. Shah was there. So he is a specialist. He's not only an MS, he's an MCH. He's a big consultant. He's a big name. Why he was there? Because everybody wants to be like him. That's why we all were listening to him. So in that comes a very important thing called as PG entrance exam. I want you people to work hard for it. And I'm sure you will. I'm sure you will work hard. Usme there is no doubt at all. But beta, एक बार मैं आपको बताना चाहता हूँ that if you think that money is the only criteria for which you are going to become a doctor, just forget it. Just forget it. I'm telling you, today money might be a criteria for you. हो सकता है आज आपके लिए डॉक्टर बनने के लिए आपके दिमाग में हो नाम, इज्जत, शोहरत, पैसा, दाम, सब होगा. You want name, fame, money, everything. But I'm telling you, there will be a point of life, because I've achieved that point. No salary, no money is worth leaving your family and loved ones at 3 a.m. in the morning to take care of a polytrauma victim. You have to have that love for the medicine to do that. होगा, एक दिन आएगा, सुबह 3 बजे को कॉल आएगा, नहीं जाने का मन नहीं करेगा. क्यों? क्योंकि if money is the only driving force, I can promise you this won't happen. You will never be able to enjoy your work. You have to you have to be obsessed about medicine to do that. And that obsession will come only if you develop a micro entrepreneurial DNA. We all have DNAs, right? हमारे DNA में एक acquired mutation की ज़रूरत है. And I want all 236 people listening and watching me right now, and anybody who watches this video later on, please make sure that you incorporate a micro entrepreneurial DNA. What is an entrepreneurship? You are probably in your 20s. मैं ऐसा मान के चल रहा हूँ, जो लोग सुन रहे हैं, आप लोग 20s में हैं, maybe early 20s, mid 20s, late 20s, or even early 30s. Entrepreneurship is got a beautiful definition. It is like living a few years of your life like most people won't. जिंदगी के कुछ साल आपको ऐसे बिताने पड़ेंगे जो और लोग नहीं बिता सकते. Why? So that you can spend the rest of your life that most people cannot. They cannot even think of spending that life. तो कुछ साल ऐसे बिताने कि और लोग नहीं बिताना चाहेंगे, ताकि जिंदगी के बाकी साल ऐसे बिताओगे जो बाकी सोच भी नहीं पाएंगे. So it is a struggle of a couple of years. It is a struggle of some part of your life, but it's not everything. Working hard, dreaming big is okay, fine. We all do that. मेहनत करना, बड़े सपने, सब करते हैं. We all do that. But you have to incorporate that micro entrepreneurial DNA. You can see a photograph on the left hand side, if you can see that, in which I'm wearing a scrub. I went to Dibrugarh to perform a spinal surgery in a lady over there. So Dibrugarh is another part of the country. I had to fly. In fact, I had to take a connecting flight via Guwahati to reach there. On the other side, if you see, I did a surgical camp in one of the villages, the remotest villages of the country. Why? Because I wanted to explore that where is the gap inside the healthcare system. आप समझ रहे हैं? There are certain parts of the country, like if I talk about Delhi, Delhi is saturated with doctors. There are more number of doctors as compared to the people living in Delhi. But if you go to the remote areas, forget about specialists, forget about super specialists, they don't have MBBS doctors. So India mein problem hai, there is a mismatch between these two. So what I want all of you to do that, please go to whatever place you want to. There has to be a vacancy, there has to be a lacuna, there has to be a gap. Ek khalipan, you will definitely find a gap in the healthcare infrastructure of that part. And I can assure you, bache, that you will excel like anything if you fill that gap. Delhi already has a lot of orthopedic doctors. So if another orthopedician comes and settles here, he is not going to make a difference to his life. But if you go to a place where, forget about orthopedics, they don't have an access to the basic infrastructure of the healthcare system. If you do something revolutionary over there, you are going to create a magic, and not only magic for those people, magic for yourself as well. You can go international then. You can do anything. People are there to support you. People are there to welcome you. Going for camps, listening to patients, listening to their complaints. Don't shy away from rural postings. Every patient is a new character in himself or herself. मैंने पहले भी बोला है, no book can teach you as much as your seniors and your patients can do. किताबों में कुछ नहीं है, मरीजों में सब कुछ है. Go for some community service as well. So this is a photograph that I took on my birthday. I normally celebrate with them. These kids, whatever you are seeing right now, they all are HIV infected kids. They have HIV either because of the wrong blood transfusion, or whether their mother was HIV, or whatever the reasons are. There are many reasons for them. So, take care of these kids. People need you. People love you. They want your love. They want your affection. You are going to become a doctor. You might have certain motives. Your father must be a doctor. होता है बहुत लोगों के साथ. Even my dad is a doctor. But the reason for me in coming to this profession was initially, okay, my father is a doctor, I have to be a doctor. This is how the genetics of a doctor family runs. Doctor बनो, doctor से शादी करो, बच्चा पैदा करो, उसको doctor बनाओ, उसके doctor से शादी करो, फिर उनके बच्चे पैदा करो. But I don't want you to do this. You have to become a good doctor, a good physician, because a good physician treats a disease. No, you're not supposed to be the good one. You're supposed to be the great one, because great physician treats the patient who has the disease. बीमारी नहीं, बीमार को ठीक करना है. बीमार ठीक हो जाएगा, बीमारी अपने आप ठीक हो जाएगी. Medicine is only for those people who cannot imagine doing anything else. So if at all you imagine yourself doing anything else, please do it right now. Don't waste your time. And if you don't see yourself doing anything else, please start loving what you're doing, or start loving what you're learning to do, because that is the only thing that is going to make an excellent life for you and the people around you. So with this, I would like to bring this to an end, and this is something that I've been using to motivate myself, and I want this statement to motivate you as well, that the world is huge and खुद से जीतने की जिद है, मुझे खुद को ही हराना है, मैं भीड़ नहीं हूँ इस दुनिया की, अंदर एक ज़माना है. So with this, I would like to, I tried to control my presentation within an hour, and I think I've done that. So all the questions are welcome. I don't want to, I want to make sure that the next speaker gets enough time. And I can see a couple of questions. Guys, can I take the questions straight away? I don't want you to be hassled.
Yes, sir. You can take the questions.
Okay, anonymous attendee, first question. Can a DNB surgeon or a DNB orthopedic person work in a trauma center? Bache, absolutely. A DNB orthopedic surgeon or a DNB surgeon or an orthopedic surgeon can work in a trauma center for sure. And I mean, if you want to work, you are most welcome. I will work with you. Second question, what is the ambulatory status? Why is the ambulatory status of patient most important in ATLS management? The person who has asked me this question, I'll give you a simple answer. Let us say if somebody gives me a call, that some relative of me gives me a call, hey Tushar, you know what, I just met with an accident. What is the first question that I'm going to ask? Yaar, tu chal fir pa raha hai na? Khada ho pa raha hai na? Are you able to put your own body weight on your own feet na? Are you able to stand up on your own na? So that is why ambulatory status is the first step with which you assess whether the patient is actually moving up and about or not. What are the alternatives for neck brace if we don't have one? I totally understand that there are certain points, like there are certain places where you don't have these fancy collars available with you. There, what you can do is you can just take, I mean, I can give you a classical example that I have done on a road. Sadak ke kinare, eat brick. I hope you understand. Brick is always there. You just take two bricks, put them horizontally around the neck of the patient and try to slightly hyperextend the neck by putting some small, maybe a cloth or a towel or a hanky or whatever you have. तो neck को थोड़ा सा hyper extend करके दोनों side से brick लगा के, so that neck is not deviated either to the left or the right. I have done that myself standing on a road, so you can do that the same. If a person is unconscious, the tongue will roll back. So how to open the airway? I told you clearly, I told you chin lift, jaw thrust, swipe the fingers, and then do the suction. That's what I told you. Why ringer lactate and normal saline? Ringer lactate is a more balanced solution than normal saline. So that is why I want you to do that. Another student has asked, can internal bleeding also occur from brain? Yes, brain parenchymal bleeding can happen. EDH, SDH, extradural, intradural, subdural hemorrhage can happen. Yes, that can happen. In a suspected spinal injury, beta cervical spine is always a priority before airway. So please understand that. Is there any different specialty like trauma surgery? No, there is no different specialty like trauma surgery. Either you can be a MS surgeon or an orthopedic surgeon and then follow ATLS and then work as a trauma expert in one of the trauma centers or start any of yours. Can plastic surgeons salvage the badly crushed limbs or it is wise to amputate? Dr. Jigar, you have to understand, I told you about MES, Mangled Extremity Severity Score. So you calculate the MES score. If the score is more than 7, just amputate it. If it is less than 7, then save it. So we have guidelines for everything. We don't, we go by the book. There is a question that polytrauma, yeah, this is a good question. Any polytrauma patient with obvious active and massive bleeding, I will control the bleeding first. Dr. Chinar Karangate, but a very valid question. I loved your question. I will control the bleeding first. I will not follow this sequence of A, B, C, D, E if there is a massive catastrophic hemorrhage. Ortho as a branch, I don't see, I personally don't feel no branch is hectic. I feel that it is you who make it hectic or you make it relaxed. For me, if I would have taken radiology or if I would have taken orthopedics or neurosurgery, I mean, my personality is going to make sure that my branch is not hectic on my personal life. Scope of MS Ortho in Mumbai, it's very good. Mumbai has got excellent orthopedic surgeons. Indian MS Orthopedics is more than enough. You can go to UK for fellowship. Somebody has asked, ortho as a good option for girls. Bache, I have taken 2 interviews of girls who are into orthopedics. They're on my YouTube channel. And if at all you find any problem, I will give you a statistics. This year, 18 girls have taken up MS Orthopedics in All India PG and other exams. So girls are entering into orthopedics like anything. Yeah, I think I have taken almost all the queries. Alternative for ringer lactate is normal saline. Internal bleeding, what is the spot treatment? Nisarg, you have to understand, if there is internal bleeding, the spot treatment is just to open it up. No other option apart from that. All right, I think that summarizes.
Thank you. Sir, you want to give some message to the young experience of the doctors?
Yes. My simple message will be, my simple message is very loud and clear to all of you. You are going to be the future of the country. I want you to understand that this limping healthcare infrastructure of the country, whether government or private, needs your boost. It requires you as the leader of the situation, not some IIM or IITs. No hard feelings for them, but the medical practice has to be run by doctors. I'm not naming, but even in a metro city like Delhi or Ahmedabad or Mumbai, a big pharmaceutical company can open up a hospital. I don't have any issues with that, but at the end of the day, it has to be run by a doctor. And I'm telling you that very soon, maybe by 2025, 50-bedded hospitals are going to replace all these fancy 600-bedded hospitals. And this has happened during COVID also. All big healthcare infrastructures are failing like anything. And that is the point where small setups are coming up. I want you to be aware of this fact, and I want you to have the vision in your head that not only you are going to have your post-graduation, but after post-graduation, after achieving the well-required surgical skill, you are going to have your own open center for 50 to 80 bedded patients, and you are going to work with other doctors. It's a very small fraternity. My students in 2013, one of my students in 2013 is right now an anesthetist with me. So in fact, sometimes I joke around also. So it's a very small fraternity. At the end of the day, we all are going to meet. हमारे रास्ते एक दूसरे से जरूर cross करेंगे. We all are going to cross our paths sooner or later for sure. So give respect to your fellow doctors, listen to them carefully, make sure that you take them into their pride and you respect them. And I'm so happy that this is a conclave by junior students, and even the senior plastic surgeons are there and the radiologists are there. So I'm happy that this is one effort by you, so that you are bringing all together to one platform. And I want more and more of these sessions to happen. The medical students are going to be the future of the country, so they should be indulged into it rather than spending time on Instagram. This is what I want.
Thank you so much, sir. It was really an honor to have you. I would like to also thank Rajneesh Bhai as well.
Thank you.
It was an amazing session. Over to you, Rajneesh Bhai.
So thank you, sir, for this wonderful session.
Thank you so much.
It was an honor to have you with us.
Thank you. Pleasure is all mine. So I'll take your leave. And if anybody, I think I missed certain queries. If there is any question that you want to ask, you can message me on Instagram. I'll be more than happy to answer all the queries. And let's call the next panelist here. And thank you so much. Signing off. Bye-bye.
Thank you so much, sir.